Hi, everyone. Thank you for getting back. Our next session kind of follows on this idea of a menu of interventions for people, and one of the ones we haven't explicitly spoken about, of course, is surgery, and we do know that it's a very successful intervention. So we've got a surgeon, a clinical specialist from the US, who's going to share some of his experience with us. Thank you very much.
Thanks very much. I'm ahead of myself here. Okay. So I'm Rob Cywes. A lot of you may have seen some of my stuff on social media. I consider myself to be a metabolic health specialist. It is a specialty that we are evolving, and our time has come based on a few facts. First of all, we have a society, and I would urge anybody here that is not part of the Society of Metabolic Health Practitioners is a society that represents what we do. Because the problem is we're all operating in little mom and pop shops, little maverick practices, doing really well with 4,000 or 5,000 patients. But how do we message this? When you're a handful of sand and you drop a handful of sand, it doesn't make a lot of noise. But when you're a rock and you drop a rock, it makes noise. We can't get representation at the US Dietary Guidelines Committee coming up with their 2025 recommendations because we're too small. So Society of Metabolic Health Practitioners, we have our university. This is part of the kind of the coursework, the informal coursework, but Nutrition Network from the Noakes Foundation has a wonderful curriculum for training folks in metabolic health. We have a journal. As of this month, the Journal of Metabolic Health is a peer-reviewed journal that was the Journal of Insulin Resistance that now represents our society. We have a textbook, and I'm very grateful that BMJ is sponsoring this and that is here to listen. However, I can tell you that the ketogenic textbook is as well referenced as any of the BMJ peer-reviewed articles, because so often we get told, oh, there's no studies, you don't have evidence, there's no studies. Absolutely false. I spent more time doing the reference section for this book, for my chapters, than I did actually writing the chapters. And then we have the clinical practices, but we're disparate. We're all over the place, mom and pops. The Unwins have a great practice, but they're looking at a few thousand patients. Global Health Quest is a group that is coming in to provide funding to bring us all together. So we are a fledgling specialty, and I would urge all of you to start looking into this and become part of us because we are allowed a voice. We certainly have, this is my Keto for Life pyramid, and you'll see it's very, very heavily addiction-based. But all the principles that have been talked about over the last couple of days are represented in that Keto for Life pyramid. Because the goal is not to lose weight. The goal is not to get rid of diabetes. The goal is to die at an old age without obesity or diabetes, metabolically healthy. Some of my study work is sponsored by Dexcom, and I'm thankful to Swiss Re for having me here today. Okay, so one of the greatest challenges, when I was doing my PhD in Toronto in the 90s, I was the last intake class of a group of physiologists, bench researchers, and the university made a distinct change toward an epidemiology program. And the fellows after me were all epidemiologists, not basic scientists. So science has shifted from causal physiology, as Ben Bickman also talked about, to outcomes epidemiology. And as you saw in the last session, the best we can do there are observational associations. An example of epidemiology is that any form of caloric reduction results in weight loss, and associated with weight loss might be an improvement in diabetes. So epidemiology treats the consequence of a problem. Obesity is not a problem. It's a consequence of a disease. If you treat the consequence without the cause, you're never going to sustainably affect the cause. So it doesn't matter what diet you use. From the cookie diet to the carnivore diet, all diets result in transient weight loss. They all work. They all work. And everybody's got these little lines here. They all work. Okay? Appetite suppression, from phentermine to GLP-1 to the big new one by Eli Lilly stock, the triple G, retatrutide, I think it's called, they all result in transient weight loss. Bariatric surgery is overwhelmingly the most effective intervention for weight loss. There's no doubt about that. If you can't eat, you lose a lot of weight. And the problem with an epi-based ideology is that now if you follow this epi association here, therefore, bariatric surgery should improve diabetes. So we're now, a large part of this talk is going to be looking at the use of bariatric surgery to treat diabetes, type 2 diabetes. Whereas in my head, in a physiologic head, my question always is, why did the person become obese in the first place, and why did they become metabolically unhealthy? What's the root cause of this disease? Because if I treat the root cause, then the consequence is going to go away and stay away. So the root cause from a physiologic perspective, you heard all day today and yesterday, is insulin resistance. And I will tell you that based on genetics, insulin resistance may have an expression, a phenotypic expression of obesogenic or diabesogenic. But most bariatric surgeons have no idea because they're so darn good at creating weight loss, this doesn't matter. So we still blame calories in and a lack of exercise when the surgery fails, and it does. We know that over the last 50, 70 years, our societal caloric consumption has gone up dramatically. And this paper talked about calorie changes driving cardiovascular disease. I would argue that it's not caloric consumption. We're not eating more protein, we're eating less fat. What we are eating is more carbohydrates. But when you see this linear increase in caloric consumption or carbohydrate consumption, you see both obesity and diabetes rates follow that. They are not the same. They are different. They are separate diseases. The traditional epidemiologic thinking, as I mentioned earlier on, is caloric excess causes weight gain, obesity causes type 2 diabetes, therefore weight loss must resolve type 2 diabetes. And we saw a clear example of that in the debate a few minutes ago. And my colleagues in bariatric surgery therefore see bariatric surgery as a final monotherapy. I operate on you, you lose weight, period, end of story. That is false thinking, because a high caloric diet and a lack of exercise may have an observational weight gain, but it's not the weight gain that causes all of these metabolic dysfunctions. We'll come back to that slide in a few minutes. This, for me, is the fundamental defining slide of my practice and my ideology. If we look at humanity as a bell curve, remember this: carbohydrates don't make anybody fat. Food does not make people fat. There are plenty of folks out there that subsist on carbohydrates to keep themselves alive. It is chronic excessive carbohydrate consumption that is the problem. In other words, it's not the sugar and the starch, it is us as human beings, our relationship with sugar and starch, using it as a drug for emotional management rather than for nutrition, that causes the excess. So that excess carbohydrate consumption, a snack is always, always, always an emotional event. It is never a nutritional event. And binge eating disorder, what I call Rottweiler syndrome, if you can imagine a Rottweiler eating. These three aspects define carbohydrate abuse, carbohydrate excess, and these are the defining things that trigger in order to help the body. So these three issues injure the body. And the human body has a lot of homeostatic interventions that preserve health. So when you eat carbohydrates to excess, the pancreas produces insulin. And as we've heard from Ben Bickman and others, insulin shoves sugar into the fat cells. There's de novo lipogenesis in the liver, fatty cells. The cells suck up that sugar and turn it into fat or store it as glucose. But every space in the body, when subjected to excess sugar, is injured by that excess sugar. In the gut, we have acid reflux, all the way through to colon cancer. Colon cancer isn't eaten by red meat, it's caused by the baked potato that you eat with your red meat. Carbohydrates injure the gut, they injure the liver, they injure the bloodstream. Insulin cleanses the bloodstream of sugar and shoves it into the fat cells. Into the cells generally. The way the cells protect themselves, and Ben did a great talk on this earlier on, is they become insulin resistant. Receptor volume goes down, receptor phosphorylation happens, you get insulin resistance. And this is where the genetics comes in. And we've measured this because I do the lab work all the time. I'll show you this in a few minutes. At some point, those cells push back. And now we've got two populations of people. You've got fat people like me, where my pancreas says, screw you cells, here's more insulin. And I can produce massive amounts of fasting insulin. My fasting insulin levels are just through the roof, or used to be when I was eating a lot of carbohydrates. So I'm highly obesogenic. I can overcome that insulin resistance because I'm hyperinsulinemic. And I keep shoving sugar into my fat cells. I walk past a donut, I gain 5 pounds. And there are a lot of populations that are obesogenic because genetically they have high insulin production capacity. And if you measure fasting insulin and fasting C-peptide, especially early morning, you can get this population. These folks have relatively normal blood sugars. So they do not have injury from hyperglycemia. They have injury from hyperinsulinemia, from the non-carbohydrate management role that insulin plays. Insulin is a quarterback hormone. So what diseases do these folks get? Obesity, dementia, Alzheimer's, cancer, steroid hormone production issues, polycystic ovarian syndrome, low T, autoimmune disease, joint disease. These are the diseases that the obesogenic folks can have. I topped out at just over 300 pounds. You know what my CAC score is? Coronary artery calcium score? 0. And I can predict, when I look at a person that is obesogenic, I can look at their blood work, and I can predict that they are not going to have cardiovascular disease. Because the human body's insulin production capacity protects you from hyperglycemia. And we can look at insulin, we can look at C-peptide, we can look at A1C, and we can determine that. However, at some point, everybody reaches a threshold where that insulin resistance overwhelms their insulin production capacity, and then they can no longer produce fat. So they switch over, and now there's a blockade. So where does the sugar build up? It builds up in the bloodstream. And we know in my PhD, I used a hyperglycemic model to create diabetes to study inflammation in the blood vessels. So elevated blood sugar, diabetes, is an inflammatory disorder of the blood vessels and the interstitial space. And so these folks, and this can happen very, very early in some populations. For example, our East Indian population, often their BMIs are normal or slightly high, maybe 27, 28, not in the 40s like myself. They become diabesogenic. These are the folks, I can eat whatever I want to eat, it doesn't matter. Because you're not checking their blood work, maybe not on the scale. They're the thin on the outside, fat on the inside. They have hyperinsulinemia, but it's low-level hyperinsulinemia, higher than normal, but they have hyperglycemia. And the risks for hyperglycemia are vascular and interstitial. So nerves and ligaments and blood vascular problems to any organs. What do they get? Type 2 diabetes, cardiovascular disease. What do we measure? We measure LDL. LDL is irrelevant. My LDL is 240. I've got a CAC score of 0. Okay? You've got to look at the coronary artery calcium score. And as family practice doctors, I would urge you to use that as your primary test, together with blood pressure. Stroke risk goes through the roof on these patients. Neuropathy, neural metaplasia, which is your arrhythmias of the heart. A lot of people don't just die of cardiovascular plaque disease, they die of arrhythmias. Fibromyalgia, inflammatory joint disease, blood clots, DVTs, vascular inflammation. So if you understand what a patient's insulin dynamics are, you can determine whether they're obesogenic, diabesogenic, or if they've crossed over. That's how we practice. And when you look at bariatric surgery is its primary effect by reducing the consumption, the overall consumption of calories, irrespective of what they are. The primary effect is to decrease hyperinsulinemia. We see weight loss, and we see a secondary effect. So secondary bariatric surgery effect is a reduction in blood sugar. Lifestyle intervention is a primary effect for hyperglycemia, and a primary effect is also produced by some of the medications, including the GLP-1s, whereas they have secondary. Lifestyle and medications can either be primary or secondary on the hyperinsulinemics. That's how I think as a metabolic specialist. Do you? So here's again a reproduction of that. So a normal glycemic person, by the way, Ben, the liver does not produce ketyl-acyl synthase, so it cannot use ketones as a fuel source, which is kind of interesting. It makes them, but it can't use them. But a normal person in their cells can use, under the influence of insulin, either glucose or ketones, and those folks have low intracellular and low extracellular sugar. On the hyperglycemic folks, where you get that insulin blockade, but they are low insulin producers, they cannot get the sugar adequately into the cell, therefore they become hyperglycemic with a low intracellular sugar, low or normal. And that's this arm over here. So you see that the extracellular sugar goes up, but the intracellular does not. They're diabesogenic. They're the tophies. People like myself or this person, we can produce massive amounts of insulin. We can keep shoving that sugar into the cells. We can make fat by de novo lipogenesis in the fat cells, but if you look at our intracellular and our extracellular glucose, both of those rise up. Okay, so this is just a photographic image of people you might see in your practice. This guy over here is a gentleman by the name of Bruce Fordyce, won the Comrades Marathon and Ultra Marathon 9 times. That's Bruce. It's also Bruce down here. He's a type 2 diabetic. He has a high CAC score. There's no way on God's earth anybody would look at this guy and say, he runs 100 miles a week, how can he have diabetes? Those guys, after triathlons that are floating in the water, often have had a heart attack. Some notes was written about that quite a bit. Arnold had his heart valve replaced, aortic valve replaced. Now, he had a calcified aortic valve. It was a congenital thing, but it calcified because of his diet and maybe some steroid use. And there is the sponsor of this disease. If you look at Tro Kalayjian over here, he's a metabolic health specialist in New York. That's Tro's journey. Dr. Jamie Seaman, a keto-gynecologist in Omaha, Nebraska. And then you look at these folks over here, everyone will say, oh, they're fat, they're unhealthy, but their blood sugar dynamics are fairly normal. Ben mentioned a camel. The healthiest camel is the one with the biggest hump. Okay, and the hump is fat. Right here is a woman with lipedema. She's the healthiest fat person you can have. Her indices are going to be excellent. Her cardiovascular risk is going to be very, very low because she has lipedema as a genetic disorder. So let's talk bariatric surgery. Bariatric surgery is primarily restrictive. It reduces how many calories you can consume. We can put a balloon in the stomach and space occupy, but more importantly, what the balloon does is it delays gastric emptying. The lap band does exactly the same. Instead of filling the whole stomach, you have a small amount of food, but the tightness of the band regulates the rate at which food passes through. Sleeve gastrectomy does exactly the same way. It turns this big bag into a tube. You eat a small amount of food. It takes a very long time to go through. So the absorptive effect in the duodenum and the proximal intestine is slowed down as well as the quantity. So the restrictive operations, you absorb what you eat, but you don't eat often and you don't eat as much. However, these operations fail because people do workarounds. We're human. We're smart. We work around. We snack. We eat sloppy carbohydrates. You eat ice cream all day. It ain't going to work. So what we bariatric surgeons do is say, no, we're smarter than our patients. Let's, for example, here, one of the most popular operations is the SADI, or the duodenal switch, becoming very popular. That is basically where you sew their mouth to their anus, and they can eat what they want to, but they don't absorb it. So it's highly malabsorptive, and then we add to that a sleeve gastrectomy, so you're only eating a small amount on top of that. So the challenge with gastric bypass and the SADI duodenal switch, which are very, very popular in my bariatric surgery community, is you're trading in the disease of obesity for the disease of malnutrition. And we see plenty of patients down the road who are malnourished. But remember that only 1.1% of eligible patients, and it's probably less than that, this is in the US, of obese patients actually have bariatric surgery. So we're really not that effective in terms of our volume. But bariatric surgeons have analyzed what happens, and there's certainly a behavioral change, a physiologic change. There's a change to hedonistic response to high calorie, I'd say high carbohydrate foods. Absolutely, this is the most important line. There is a massive reduction in calories. So whether you do it by intermittent fasting, whether you do it by some calorie-restrictive diet, or whether you do it by surgery, surgery is the most potent over there. Therapeutic carbohydrate restriction, gastric bypass patients have dumping. Sleeve gastrectomy patients have dumping. These guys will eat toast, but they won't eat ice cream. These guys will eat toast, will eat the ice cream, but they'll struggle with the toast. But they have dumping. There's no dumping with a lap band. There is a change in the microbiome when you do diversionary surgery, so they get SIBO. These folks don't. And then when we look at the intestinal hormones that regulate appetite, GLP-1 and the other incretins go up with a gastric bypass, because you're bypassing the area in the proximal duodenum where GLP-1 is secreted proximal duodenum and distal small intestine. But the proximal intestine, it's avoided, not so much with sleeve or with a lap band. GIP is decreased. Amylin, which is the drug that most of you probably don't know about, but it's very, very popular in the pharmaceutical industry because amylin triggers insulin. This is a new experimental drug that is being developed in pharmaceutical trials. Amylin is increased postprandially, no difference here. Peptide YY, one of the 5 satiety hormones, increased in fasting equivalent. So we see hormonal effects, but these are minor relative to the caloric reduction, and you override any hormonal effect by increasing the frequency with which you eat if you are a bariatric surgery patient who cannot tolerate killing their best friend, which is eating. This is probably the most important, by far the most important slide of this discussion, because what we're talking about here is Phil Shower's work on the Stampede group of investigators, where they said, okay, bariatric surgery creates significant weight loss. We see about a 10-point reduction in BMI. Now, these folks started with a slightly lower BMI of around 36, but we see significant weight loss, and it's not that dramatically different between gastric bypass and sleeve. But we also noted when we saw those patients, their diabetes got better. And I think that's the mistake that was made on that panel. We see an improvement in diabetes, but it's a secondary improvement because of the caloric reduction. If you look, so we definitely see over medical intervention, so diet and exercise, really not very effective weight loss results. Much, much better weight loss results with bariatric surgery. The green line over here represents, that's from the Ozempic, the Step 4 trial, which is a GLP-1 agonist. And you can see the weight loss, and we'll discuss that in a few seconds. The red line is my practice. And in my practice, now 100% of these patients had surgery. Okay? In my practice, this is all comers that are obesogenic. All comers that are obesogenic. 42% of them had surgery. Okay, so it's a hybrid. I think that the number is around 37% of them were using GLP-1 agonists, but they were all on a low carbohydrate diet. And we saw substantially better weight loss overall than pure surgical patients. You can see the numbers down here, sustained over 5 years, primarily because of a ketogenic diet. Now, let me explain my GLP-1 agonist use. I use it for 120 days shortly after induction. It is not a permanent medication for me. I use it like we use Chantix, like we use Antabuse. I use it to induce and to improve insulin resistance and to induce a ketogenic diet. But the folks out here, whether they've had surgery or not, are primarily doing this and maintaining this weight loss because they have changed their relationship with sugar and starch and eating from an emotion management perspective. So let's go across now to the diabetes side. So these guys said, okay, we're seeing an improvement in diabetes. Let's do surgery on these folks and see what happens to the A1C. So these are your diabesogenic patients. And they saw a dramatic improvement in A1C that most endocrinologists would be proud of. But for me, a normal A1C is 5.2, not below 6, or below 6, below 7. So they saw a decrease, but they saw a decrease from 9 to 7. That is still an awful, awful number in my book if you're a type 2 diabetic. The GLP-1 agonists, again, the STEP trial, we see the difference there. And then diet and medication, we see how awful that is because we're not talking about carbohydrates. In our practice, zero of these patients had surgery. We don't operate on diabesogenic patients. So 0 of these patients had surgery. They had medication and they had TCR, therapeutic carbohydrate restriction. 5 years out, A1C is 5.5, I think it was, 5.4, okay? With several of them in the 4s. That's what proper medical management should look like. I can't report that. I can't publish that. So most of my patients are experts. By the time they come to me, are experts at failing weight loss programs. They've tried them all, they've failed Atkins, they've failed every form of weight loss. Because obesity is a chronic disease, it's not something you do, you have to change who you are in order to sustainably lose weight and keep it off. We use in our practice 4 sequential therapeutic strategies. The first one is the dietary side, nutritional modification, using a combination of time-restricted eating or intermittent fasting and therapeutic carbohydrate reduction in a progressive way. You don't have to start your diet everything at once one day. You eat an elephant in little pieces. You slowly evolve to that because you're changing behavior. We use a heavily cognitive behavioral therapy-based diet. Our psychologist is as important as our dietitian. And we change the primary form of emotion management in our patients. Not just creative arts, human connection, exercise, spirituality, meditation, healthy sex, and healthy sleep. Those are important. We will add in pharmacotherapy, incretins to improve insulin resistance, and if somebody warrants it, in my practice, the enemy is being fat. and we will throw every tool at you to help you not to be. So there are certain patients, not all of them, that warrant bariatric surgery, but that's the algorithm that we use. Now, let's look at the evidence. After 2 years, lifestyle intervention, approximately 5 pounds of body weight. To someone like me, that's a bowel movement. That's not weight loss, okay? The Step 4 Ozempic trial, 10.6% body weight loss. But look at this, weight regain 48 hours after switching to a placebo, 6.9 of that, 6.9% from 10.6%, only a 6.9% regain after 48 weeks. That's less than 1 year, or right at 1.5 years. We're talking about a lifetime. So Ozempic does not work as a monotherapy. Weight loss, 1 year greater than 50% with bariatric surgery, but by 10 years, 85% of those patients have regained some or all of their weight. So all these interventions are plagued by weight regain and a consequence going back to diabetes, cardiovascular disease, metabolic disease. Sustainable, not obesity management, but sustainable insulin sensitivity is best managed by a multidisciplinary clinical team using a multimodal strategy that integrates nutrition, pharmacotherapy, and psychological behavioral therapy. Here's the problem. It's not covered by insurance. It's not covered by insurance. I cannot bill for obesity management. I can bill for insulin resistance. I can bill for metabolic syndrome in the US. Most insurance companies will not pay unless there's a rider for obesity management. Think about that. Bariatric surgery may be a key component in addition to these to manage select patients. This is Archie. Oh my God, don't operate on a 16-year-old. Here's a 16-year-old with a BMI of 86.7, triglycerides of 766, LDL low at 87, everyone's kumbaya happy, I'm not. Hemoglobin A1C of 6.7, so even though he's obesogenic, he's already crossed over to the diabetic side. This is, by the way, routine blood work that I do once or twice or 3 times a year on all my patients. That's how I can evaluate you. So fasting blood sugar, 166, fasting insulin, 47. Look at the changes. BMI in the course of 3 years, 86 to 33. This is a 19-year-old kid, these results. Triglyceride from 766 to 94. LDL, thank goodness it's come up, 212. We didn't do a CAC score on him. A1C 6.7 to 5.5. Fasting blood sugar well down. Fasting insulin from 47, obesogenic, down to 7.9. Still slightly insulin resistant in my books. C-peptide from 5.35 to 2.1. HOMA-HR down. The inflammatory markers, ferritin is an inflammatory marker from 413 to 56. Uric acid is an inflammatory marker. This is how we track our patients. And if you don't have this data, you don't know what is happening metabolically inside of your patients. So insulin resistance, the physiologic thinking, is that a high-carb, instant gratification, drug addiction type diet involving snacking and binge eating causes insulin resistance. Therapeutic carbohydrate restriction and a change in effort-based self-care and emotion management restores insulin sensitivity, and when you restore insulin sensitivity, obesity, diabetes, and metabolic disease goes away and stays away. We use bariatric surgery, amongst these other things, as a tool on a journey, not as an endpoint treatment. But chronic excessive carbohydrate consumption causes insulin resistance, causes hyperinsulinemia, and causes all of these metabolic disease. Of that, I have clinical evidence. So the final slide, human metabolism is always physiologically driven. The human body will always protect itself and has homeostasis to do so. You cannot become obese without insulin resistance. Carbohydrate abuse, carbohydrate addiction, not calories, cause insulin resistance. Your hormonal response to chronic excessive carbohydrate consumption is genetic. And that the phenotypic expression may either be obesogenic or diabesogenic or a crossover. Metabolic disease depends on when hyperinsulinemia peaks. What is your body's peak insulin production capacity? Bariatric surgery results in weight loss but does not treat the cause of obesity, but is still a very useful tool when you've tried all the others. Treating insulin resistance by multimodal therapy treats root cause, and the healthiest state of being, the Benjamin Button of healthcare, is to be fat-adapted, insulin-sensitive, because that is the healthiest hormonal state. Thank you very much.
Thank you, Rob. So Rob kind of didn't realize he was at a conference. He thinks he's still practicing, so he's time restricting you guys from your coffee break later, let me say, and probably preventing some addiction there with the caffeine. So that's great. We're way over time, but I'll go for one question if there's a burning question that anyone. David, go for it.
That was so interesting. You mentioned carb addiction several times. In clinical practice, concerning bariatric surgery, one of the problems I've got is they go for bariatric surgery and they become so anxious afterwards and depressed, and a number of them start drinking. I think some of those are actually carb addicts who you've put into sort of low-carb jail with the bariatric surgery. So my question is, in your practice, are you screening for carb addiction before you or how do you deal with this?
Right, we don't screen for it, we assume it.
Right.
If you've had 5 DUIs and you've got liver disease, you're an alcoholic.
Yes.
Okay? If you are morbidly obese or have type 2 diabetes, your relationship with sugar and starch, snacking and binge eating is broken, and it never will be fixable. So you have to protect you from yourself by distancing yourself and putting other behaviors that more effectively manage emotional need in the interspace between eating and drinking as a lifestyle and eating for nutrition. And that might be physical activity, which everybody promotes, but it might be creative arts. You know, if I said to you, you have to play the trumpet, and you don't feel like playing the trumpet, it's not in your wheelhouse, you're not going to do it. But we tell every fat person they must exercise. Not everybody is an athlete. But some people are thespians, some people are artists, some people are more spiritual, some people prefer human connection. It's what defines where you go to for emotional restitution that defines who you are.
Thank you. So you're not doing bariatric surgery without long-term support, is that?
You cannot do it. Well, you can do it, of course, but they're going to fail like they fail.
And they do.
Yes, they do.
That's brilliant.
Yep.
Thank you. Good.
Thanks very much. Thank you, Rob.